Hello, thank you, Sandra. And thank you, Julia, for your views on lymphedema, because as you said, it's a bit tricky sometimes. And unfortunately, it's due where you live as well a lot. But
Yeah.
we'll talk about it. So my name is Carla. I am the clinical lead of the lymphedema service at UCLH. My background is physiotherapist, and I am as well very passionate about lymphedema. I think you really need to be if you work in lymphedema, because we are really few working in that field. That's the main problem at the moment. Can I have the next slide, please? So I did put my email here. Just feel free to email me if you have any questions or anything that now you cannot think of, but then later on, maybe in the week or later on, you think, oh my, I didn't ask that. So just email me. I'm really happy to respond to anything. Can you next slide, please? So I'm gonna ask you to start treating lymphedema from today, all of you, because you can actually start with 3 points. And this is what we are lacking in lymphedema, the knowledge of the power we have, everyone actually, that we see patients that go through cancer. So we are all responsible of that, and we need to be aware of just basics sometimes, and they make a huge difference. So I'll talk about it through the slides, but these 3 points are exercises. Sometimes we call it activity because some people feel that exercises are overwhelming. So it's just movement, what we need with lymphedema, positioning, and skincare. Next slide, please. And can you actually make all the rest of the causes of edema to appear? Clicking, please. So first of all, not all swelling is lymphedema. So it's very important when we know the origin of the swelling. Swelling is just a sign of the body telling us something is wrong. And it will vary a lot if we have a cardiac problem or we have lymphedema, or if it's because of an infection. So it's really important that someone actually have a look and sees what is actually happening to have the appropriate treatment. Um, um, Hypoalbuminemia, maybe you don't know about. This is actually in palliative care, we find it a lot, is when albumin is low, and they actually swell up generally. And we still can actually do things from the lymphedema point of view, but until the albumin is not above 30, the swelling won't actually get better. Okay, next one, please. So what is it, lymphedema? So lymphedema is when the lymphatic system doesn't work. It's because it's damaged, because it from birth was not working, or for traumatic consequences like cancer treatment that I'll go in more detail. But I want you to know that it's not only cancer that actually is a consequence of lymphedema. It can be an accident as well, or a side effect of a medication, cellulitis, or even you are born with it. And some babies will be born with it, but some others will develop swelling at puberty or when actually they have an accident, because the lymphatics are coping until they are overwhelmed. Once actually they are overwhelmed, if you have a diagnosis of lymphedema, it's very difficult to resolve. So I just put here the first prevalence estimated one that we had kind of out there in 2003. And this is very, actually, it was the first one that actually made us kind of think, oh my God, what are these numbers? And because it's a lot of people in UK, if you look at it. But this is 2003, and we'll see that now the numbers are different. Can we have the next slide, please? This is very busy, and this is only to let you know. This is a primary, it's genes that they have discovered causing primary lymphedema. When I started in lymphedema quite a while ago, I think it's more than 16 years ago, we knew 3. And in those years in St. George's Hospital, they've been doing a lot of research. So all these are responsible of lymphedema in some sorts. Next one, please. So it's very important that you understand how works the lymphatic system. So the lymphatic system is a system that helps our body to drain our fluid that we generate every day, and it actually ends up in the interstitial space. So it helps to drain all this fluid, um, and it all starts, or the majority of the system, 90% of the lymphatics are starting underneath the skin, and then they go deeper. From the legs, they'll go all the way up to the neck. From the arms, they'll go all the way up to the base of the neck again, and head and neck will drain the opposite. They'll go down. So it finishes on the subclavian vein or the jugular vein, where everything is poured there. The veins do whatever they need to do. But it's only one way system and is affected by gravity. So this is when you will need to actually know how to actually avoid gravity in patients that you think that may can have the lymphedema. So within these vessels, we find time to time lymph nodes, that the lymph nodes will start actually to filter all this fluid and to fight infections. So these lymph nodes, we normally find them in blocks on the inguinal region, on the pelvic region, axilla, and side of the neck. So, and these are targeted in cancer treatment. So this means that part of the system will be damaged, and all the way down from there, it will be at risk of developing a problem like lymphedema, because the drainage can be impaired. So I always say that it's like a tree root, yeah, because it actually starts very little and then it forms bigger vessels. Can I have the next slide, please? So how it works, the first lymphatic is underneath the skin. And this is very important because this means that it's very superficial and we have tools to actually start moving this fluid. And the first lymphatic will have little doors, and that they'll open and allow this fluid to go in. This first lymphatic has filament anchors attached to the skin and surrounding tissues. So it will be very important, this skin, to be moving to pull these filaments to open these doors and have all this fluid to go into this first lymphatic. So the lymphatic system is made by chambers. So, and they have valves in between. When we have this first chamber full, the same system will contract and will go to the next one. This means that if we have the first chamber full, it will go like the domino effect. Now, what we don't have with the lymphatics is a major pump, and we'll need muscles to help the pumping of this fluid. Yeah. So this is why exercises and moving will be very important. The next thing that the lymphatics do, and it's crucial, is immunity. So within them, we'll have our immune cells fighting infections. So it's very important to know that patients who are at risk of lymphedema, or they have lymphedema at risk of cellulitis, that is a skin infection, because the compromise of our immunity. Can I have the next slide, please? So what what why we have lymphedema after cancer treatment? So there are known risk factors, and these are surgery, because they remove lymph nodes, radiotherapy, because they are so superficial that the burning can affect the lymphatics, scar tissue formation. It can be either radiotherapy or the same surgery. So the scar tissue will be actually acting like a barrier of this drainage. Um, Infection can cause bleeding and impair actually furthermore the drainage. And we need to be aware that cancer itself can actually be causing obstruction. So we really need to be actually attentive here. Obesity is a clear link now that can cause lymphedema, and it's more difficult to manage lymphedema when you are obese. So we always recommend to actually keep your weight under healthy limits. Medication, there are a lot of medication that cause swelling. And one of the ones that we find the most responsible is amlodipine. Amlodipine is a hypertensive medication, is a calcium channel blocker, and we know can paralyze the lymphatics. So if you find that someone is on amlodipine and has lymphedema, the GP should actually change it to a non-calcium channel blocker. Next, please. So it's just an imbalance between lymph load and lymph drainage. So imagine these canals. If someone blocks one of them, or if you have a lot of rain in one of them, what will happen? If it actually finds rerouting, that's fine. If not, it will actually be flooding the land. Next one. Now, we don't have enough evidence. I did put some data here, but the problem we have with data is that the articles don't have enough patients in the study. They are comparing different things. So this is just guidelines, but this is actually not the real numbers. And you can see that midline, we struggle even more. Midline means head and neck, breast, and genitals. So we know about arms the most because breast cancer is the one that has been more studied. But you can have lymphedema everywhere in your body, and it gets more difficult to manage when it affects the midline. So we know breast cancer treatment can cause more or less 25% of arm lymphedema, but no one knows about breast. And it actually can, there are articles that they are saying that it can be as high as 75%. So this is tremendous. Head and neck, you can either have really low or really high. And that's why probably it's because it depends on the hospital or on the country that the study has been taken on, because surgery will have a lot of things to do with head and neck lymphedema. So what happens is that lymphedema is underestimated because it remains under-recognized and under-documented. So until we don't have this sorted, it will be difficult to know the real figures. Can we have the next one, please? This is just for you to be aware. This is we don't have one lately of kind of comprehensive about around UK. As you see, we are again estimating, and we have two teams doing a lot of actually research on prevalence, and one is in Wales and the other one is in Derby, and both of them they estimate different. So and if you can see about the population of the UK, it's actually quite disparity among them. What it actually worries me is that this is the ones that we know, but there are a lot of people under that are not diagnosed out there. So it's like really feeling for them. For the Derby estimation, they found that this is actually a 3.9 per 100 of population, but it rises to 28.7 when we are talking about population over 85. This means that our elderly are more prone to actually have lymphedema. And we are aging more. Our population is aging more. And then another thing that the Wales found that it's quite actually eye-opening is that in 6 years, it went to 2.6 per thousand to 6.4. So in 6 years, the prevalence actually went up a lot. So this means that we are actually having more people having lymphedema because they are aging or because they have actually survived cancer. That is wonderful, but this actually means that we have a lot to do. Next one, please. So, and these actually, Julia actually sum it up very nicely, how the impact on the individual, because we are talking about lymphedema in general, but when it's you that suffer lymphedema, it's actually quite difficult sometimes to find a service. And this is because in England, we don't have a national strategy. So we have it in Scotland, in Wales, and Ireland, but we don't have it in England. So that means that no one knows what is commissioned, for who, for what. So it depends on where you live. You actually have one service or another. So this actually was a survey that they did in Southwest London quite a while ago, but actually it's shocking that they found that 80% had to take time off work, or that 50% had cellulitis. This means that you need antibiotics for 2 weeks, or actually some they need to actually have an admission because they need IV antibiotics. So the impact on one's life is actually quite substantial. And what is really more shocking is that 33% of these people didn't know that they had lymphedema, and 36% they didn't have treatment. So we really need to actually be acting on this more actively. Can I have the next one, please? So for the cancer-related one perspective, as we said, if this lymphedema is because of cancer treatment, what you'll find probably is that clinics will normally ask for 3 months after cancer treatment has finished. And this is because of the surgery or after radiotherapy, we are facing post-radiotherapy or post-surgery edema. But if it's very clear that the swelling is related because of cancer treatment, just refer to any local service, and then they can actually start actually giving advice, because this means that that person will be at risk. Yeah. So, and the thing is, anyone that has had surgery with lymph node removal and radiotherapy is at risk of developing lymphedema. So consider the referral as well, even if you don't see swelling. If a person, for instance, has had gynecological treatment and they feel that the legs are more heavy, because sometimes it's not significant, the swelling that they have, but they can tell you, oh, I feel heavy and it's achy. So maybe they are developing lymphedema, and lymphedema is a chronic condition that if you get early, it's more manageable. So it's really important to detect early, to keep it mild, because then it's easier to manage and you don't have so much risk of cellulitis. Okay, so before referring, really actually what you need to actually ask, if you kind of are not sure, is check if they have a blood clot, or if suffer from an infection, if they have cancer recurrence, because cancer recurrence is actually part of when a lymphedema occurs or gets worse. And then if you suspect that it a cardiac or renal component, just double check with the GP. Very important. If they have mobility problems, please refer to a physiotherapist. Next one, please. This is actually our pathway for North Central London. I just put here the emails, and I can distribute as well with the slides the referral form to send to these services. So in North Central London, we have us covering Camden and Barnet. We have Islington, Haringey, and Enfield. But if someone actually falls out of these areas, I'm happy if you actually send me an email with the postcode of the GP, and I can actually guide you a bit, because we know about London and surrounding London services a lot, because as UCLH has so many people that live outside London, we need to send them locally, and we know services. So if you are not sure, we are really happy to signpost. We are doing it already. Next one, please. This is a slide that is very important, because this is what we do as a therapist. But as you see, it's part of our treatment, what I said that you can start. Skincare, exercises, positioning. You can as well say that it's better that to lose weight if they are obese, and it will be crucial for us to support the patient and educate, because if you know what to expect, what to look for, how to manage, or where to go if it gets worse, then it's actually better managed. Next one. So skincare that you can do. It's to maintain elasticity, to promote those filament anchors to open, and to actually avoid an infection, because dry skin will crack. And if it cracks, a bacteria can come in. So what we do, moisturize the skin, check if there is any cracking, put antiseptic cream and keep an eye, most likely will heal. For head and neck patients, it's not only outside, it's inside the mouth. The majority of cellulitis in head and neck comes from inside the mouth. And treat any wound and treat any skin condition, eczema, dermatitis, all these needs to be treated, otherwise it can crack. Next one. So this is actually the management of cellulitis and lymphedema. because the lymphatics are the responsible of our immunity, it can be compromised. So what is it that it's different when it happens, lymphedema from cellulitis? So lymphedema goes up and down very slowly. Cellulitis goes up very quickly. So anything that is sudden swelling normally is not and cellulitis will be going up very quickly. It will be red, warm, painful. They can actually feel flu symptoms. So if this happens, they need to go to the GP, call 111, or go to A&E if they feel really unwell. And then they will need 2 weeks of antibiotics. There is a consensus management of cellulitis and lymphedema that it's available to download, and I'll be actually as well giving to you if for anyone interested. And it's a guideline, so which antibiotics work better, what to do, and when to review for recurrent cellulitis or things like this. So next one, exercise. This one you need to do as well. Exercise means that if we don't move, the muscles don't help. So it doesn't need to be exercises, but we'll actually be promoting swimming or walking or Pilates or yoga. It doesn't matter. Move, move, move. We did develop an exercise program with Cancer Research UK, and you can actually access it in this link. And this is for patients at risk or with lymphedema, and they are very safe and they can do. So you can actually give this link to any patient that you think that can benefit from it. And as I said, very important to actually get good posture, prevent frozen shoulders, and all this that actually a physio can do. So any of this that you think, then send them to physio, because then it will promote better muscle pump. So positioning, as we said, the drainage of the head and neck goes down. This means when we are wake up and about, gravity helps the swelling. Great, but you go to bed and gravity is not helping anymore, but it's causing swelling. So head and neck lymphedema patients will benefit from sleeping with some pillows to have an inclined position to actually get this down. Postural hygiene, head and neck, if you tilt your head forward, you actually build up the swelling in your submental area. So very important, iPads, books to be on eye level, not down. And then the position of the shoulders and neck will be very important. Next one, please. Upper limb against gravity is the opposite of head and neck. So very important. When we are up and about, probably they'll tell us that evening time, the swelling is worse because the gravity has actually been affecting this drainage all day long. So very important to sleep in the bed, on the bed, not on a recliner chair. And when sitting down, they can support the arm with pillows at heart level. And if actually they open and close the fist, even better, because they'll be pumping this fluid. And try to see if someone actually has had treatment recently and they have this position kind of wanting to protect the arm, not moving and very bended, to actually encourage them to extend and to move. Because otherwise, imagine a hose in your arm that actually drains up. So if the hose actually is bended 90 degrees, it will be an impingement on the drainage. Okay, next one. Lower limbs again, affected by gravity. So very important to go to bed at night. And when sitting down, legs up. But be careful with stools, because if you don't support the back of the knee, it is going to be painful. So ideally, all the leg needs to be supported. And then avoid standing still for long periods of time. Next one. This is our contact details. You can either email me directly or the team. As I said, we are signposting for a lot of people now, and we only require the GP postcode. So it's just, can you actually tell me which lymphedema clinic this patient belongs to. Normally, we know quite well in London. Next one. Next slide, please. Okay, so when patients ask where can I actually can have some reliable and nice information, it's the Lead Support Network. This is designed for patients, and it's very actually understandable, and they have a lot of resources there. You can actually as well have the consensus management download by them with this one. The British Lymphology Society has a lot of things as well. We'll actually as well share with these 3 lymph facts because I think they are very powerful to have on hand. And then any cancer website, normally they have a lymphedema space there with Cancer Research UK or Macmillan Cancer Support. Next one. So just please treat lymphedema from today, because if you actually give this advice, moving for the muscle pump, avoiding gravity, and then being careful with the skin, you're starting treatment even before they are seen by a specialist. So this is, yeah, it saves a lot of travel. Next one. Thank you very much.